just thank MDA for organizing this conference. This is a really exciting time in Duchenne muscular dystrophy, and I've been treating patients with Duchenne muscular dystrophy for 35 years now, and I'll have to say that this is really the most exciting time of my career. There's really just so much happening right now. I woke up at 4:30, so I misspelled the word novel. That being said, we'll go ahead and get started. We actually have a lot to share with you this afternoon. So Duchenne, you're all aware, this is an X-linked disorder, rare, relentlessly progressive, ultimately fatal with our early death. Death is too early and results in progressive paralysis, respiratory failure, cardiomyopathy, and ultimately death. Although the lifespan is improving enormously, I just saw a 41-year-old patient with Duchenne just on Wednesday in my clinic, and that was a patient that I diagnosed when he was, I think, six years of age, and he's 41 now, and looked across the room and saw his toddler brother, who also had calf hypertrophy and difficulty getting off the floor, and so diagnosed his brother as well. Fortunately, they're both still with us today, and with good quality of life. So just to remind you, the protein, the dystrophin protein is an essential muscle protein. Here's a schematic on the left showing a single muscle fiber, and there's these filaments inside that fiber. You can almost think about it as a cable of lots of little filaments or fibers inside. These are the actin and myosin filaments, and if you really zero in on that in the middle diagram, you can see that the dystrophin protein is located on the inside of the muscle membrane, and one side of it attaches onto these actin filaments. The other side actually attaches onto the dystrophin-associated protein complex, which crosses that membrane. And if we do an immunofluorescent stain on the right, you can see where the dystrophin protein is staining, and it really serves as this flexible link between the contractile machinery, which is the actin and myosin filaments within the muscle fiber, and the extracellular matrix outside of the muscle cell. And what it serves to do is protect muscle fibers against contraction-induced injury. And this is really, you can think about it as a shock absorber. It's really a molecular shock absorber, and there is the dystrophin protein lying on the inside of that muscle membrane, and it is actually folding and unfolding. So you can imagine where it really acts as essentially a spring to decrease the wear and tear injury that can occur to that sarcolemmal membrane. And so if you don't have the springs, you can imagine your car without its shock absorbers is going to break down prematurely. In fact, what happens when we're lacking, you can see on the left there's this little tear or break in the sarcolemmal membrane. And so you have this mechanically weakened muscle membrane that's prone to tears. When there's tears that occur, you have calcium, which is present in abundant quantities outside of the muscle membrane, which leaks inside of the muscle cell. And that calcium then is toxic to the cell and can actually be toxic to the mitochondria, which are the energy-producing factory within the cells. There's activation of destructive enzymes, and ultimately what you get is this segmental, what's called segmental necrosis there on the bottom left of the muscle cell. And when you look over on the right, as a result of these tears in the muscle membrane, the creatine kinase enzyme actually leaks from within the cell to outside of the cell. We can actually measure it in the bloodstream, and that's why the creatine kinase value is so excessively high in Duchenne patients, and patients will with a normal CK value maybe in the order of 200 or 250. The CK of a Duchenne patient at presentation can often be 15 to 35,000. So really quite abnormal. And so I'm going to start by discussing the story, the really exciting story of AAV gene therapy. And AAV vectors are really the leading platform for gene replacement in neuromuscular and other genetic disorders. And so these AAV viral vectors are actually, they're essentially the bus to carry the replacement gene into the targeted muscle cell. And so the actual AAV capsid actually binds to the cell membrane. You then get the AAV capsid actually gets into the inside of the cell, and ultimately it delivers its replacement gene DNA into the nucleus of the muscle cell. There's transformation of that viral vector DNA into what's called episomal DNA, which is circular, and then that message from that DNA actually gets transcribed into RNA. It's translated then out to the outside of the nucleus, where it then is involved in actually the production of the dystrophin protein. And the dystrophin protein, which is really amazing, is actually localized to its correct position inside of the sarcoidal membrane, and can actually then serve to help the patient. So this is really the structure of the dystrophin protein. There's really some key domains here that we've learned over the years that are really critical parts. There's this actin binding domain that binds onto that actin scaffolding. There's the membrane binding domains. There's also the C-terminal domain, which binds onto those series of dystrophin-associated proteins. And then there's these hinge regions, which are really important for maintaining sort of the structure, the configuration of that spring. And we've learned that we can get by with perhaps 3 hinged regions. We can't really get by with less than 3 hinge regions. There's normally 4 hinge regions, but we can actually get by with just 3 hinge regions. And this brings us to the story of microdystrophin gene therapy, which really began in the United Kingdom with King Davies, who was at Oxford at the time, who was a geneticist, who really made a very astute observation. There was an individual who actually was diagnosed at the time with Becker muscular dystrophy. That individual was in his 60s, but had actually served in the military in their 20s. At age 45, they had actually climbed up some of the cliffs in the United Kingdom with just a walking stick. And at age 60, they were still ambulatory with a wobbling gait, needing just a walking stick. And the thought was this patient would have Becker muscular dystrophy with just a point mutation, perhaps a small in-frame mutation. And this patient actually had a classic X-linked inheritance pattern, so there was multiple members, males in this individual's family who had very similar mild disease progression, and were some were actually weightlifters, and they all essentially ended up ambulating well into their 60s. And what was amazing about this particular patient is this patient was missing 46% of their dystrophin gene. And in fact had a huge deletion from exon 17 to 48. So there was this large portion of the gene which was absent. It was the middle portion of the gene which was absent, and that really gave rise to this concept that perhaps we could actually design a replacement gene which would be sort of patterned after this patient's gene, and that gene would actually be small enough to actually fit into an AAV viral vector. The AAV vectors cannot carry the full-length dystrophin gene. It's the largest gene that's ever been identified in the human genome. You can't fit the full-length gene into a viral vector for gene therapy, but you could theoretically fit this mini gene or this microdystrophin gene into an AAV viral vector. And this just demonstrates the critical regions of the gene, which we showed in the previous diagram. This patient from the United Kingdom who was missing this huge central portion of their gene, and you can see the correspondence to the 79 exons within the dystrophin protein. And so here's this individual, 61 years of age, still ambulatory. Here's their dystrophin protein on the left. And so the companies that are in the gene therapy space have really designed and engineered the gene that they're using for the AAV gene therapy after this patient's dystrophin protein. So here's the actual Sarepta 9001 dystrophin protein. You can see it's very similar to this patient's protein. And all the other companies that are in the AAV gene therapy space treating Duchenne patients have very similar microdystrophin gene constructs with some just very slight variations, but they're all quite functional. Essentially, what we're doing here is we're replacing a long spring with a short spring, but still a functional spring nonetheless. And so this has given rise to a lot of work that's been done preclinically. Here's the different microdystrophin programs that have been developed by Sarepta Therapeutics and by Solid Biosciences and Pfizer, and there's also several other gene therapy companies in the space as well in Europe and other places. These are really the first three, and when you develop this gene therapy, you actually have to not just fit the replacement gene or the transgene, which ultimately produces the shortened spring, but you also have to fit in a promoter which drives the tissue-specific expression. So you don't necessarily want genes being expressed in other off-target tissues. And you really want the gene expression to be specific to the skeletal muscle and the cardiac muscle, because those are the tissues you're trying to target. And then the AAV viral vector as well. And in the case of Sarepta, they've actually utilized what's called an AAV RH74 AAV vector derived from a rhesus macaque primate species, which actually doesn't cause disease in humans, and may have some advantages in terms of the safety profile, the tendency towards complement activation, and bad pathogenesis that can result from immune-mediated untoward effects. And so there's really a variety of ways in which we can actually look at effectiveness of gene therapy. We can actually do muscle biopsies and look at the vector genome copy number. So how efficient is the transduction of that replacement gene from the virus occurring? We can actually look at the level of the dystrophin expression by muscle biopsy and Western blot. We can also look at the localization of the dystrophin protein to ensure that it's actually localized to the correct location. And also, normally, with absence of the dystrophin protein, you actually get dropout of those other dystrophin-associated proteins, some of which cause limb-girdle muscular dystrophy. And so what you would hope to see is not just restoration of the dystrophin protein, but also improvement in the levels of some of those other dystrophin-associated proteins. And indeed, when we do biopsies with patients, we actually see some improvement in the sarcoglycans and some of those other dystrophin-associated proteins. I mentioned the huge elevation in blood CK levels, so you'd also hope to see normalization of the muscle microenvironment by looking at the CK, which is actually a blood biomarker, which can show us maybe a short-term signal. And then we can also look at functional endpoints such as the North Star Ambulatory Assessment and time function tests and other parameters. So if we look at, and I'm just using the Sarepta gene therapy really as an example here, I think there's very, very similar preclinical and patient or early patient data from some of the other gene therapy programs that have been coming out. I think that Solid Biosciences has recently shifted their AAV away from AAV9 and are actually going more towards an AAV8 platform, which is much more similar to the AAV-RH74 that Sarepta utilizes. But you can actually look at the staining levels this is animal models of muscular dystrophy. So the middle picture there is a mouse with muscular dystrophy. You can see really complete absence of the dystrophin protein, but the mouse that's treated with this gene therapy, you can see this robust expression. I mentioned the restoration of the dystrophin-associated proteins, so you can see not only does the animal showing significant levels of dystrophin, but also the transmembrane sarcoglycan or the dystrophin-associated proteins are also being restored. If you merge the images, this is really what you see. And the data is really that has been coming out from Sarepta in their clinical development program has been really quite robust evidence of increase in vector genome copy number, increases in Western blot on the order of 23% to 70%, so orders of magnitude higher than we see with any exon skipping program to date. And the latest data that Sarepta has actually made public from their confirmatory trial actually showed a 34% expression of the dystrophin protein. And then also you can look at immunofluorescent fiber intensity and percent dystrophin positive fibers, and the results all look quite robust. The data also shows that these children who have been treated with gene therapy are getting really a quite significant drop in their CK values on the order of 11,000 point decrease in their CK from within 12 weeks of treatment. So it's not uncommon for us who treat these children to see the CK going from say 18,000 down to 4,000. And this occurs really quite quickly after the gene therapy treatment. There's also data that's been published that shows an improvement in the fibrosis. So there's a mean decrease in collagen that occurs after the gene therapy treatment. And this is actually data that was presented also to the FDA, really demonstrating this relationship between the Sarepta dystrophin expression and the improvement in NSAA total score over 1 year. And what's interesting about this data is you see that once you get above 30% levels, there's really not really any continued improvement in function, but so the North Star kind of flattens out. That's called a saturable response. So it's great to have 70% expression, but the functional gain for the patient is not necessarily that much better than if you get 40% expression. Once you get to like 30% levels, it seems to be this saturable response. Makes sense because there's a lot of patients with Becker muscular dystrophy that have significant reductions in their dystrophin protein, and they're doing awfully well. The mean age of survival worldwide for Becker muscular dystrophy is about 67 years of age. But you can see that once you get above levels, all treated patients are showing improvement. But certainly when you get above levels of say 10%, you're seeing significant improvements in the NSAA value. We also, in these clinical trials, we do a test called the North Star Ambulatory Assessment. This has been a well-validated test. There's 17 items that are assessed. And these actually go from sort of those tasks that are the most difficult to perform So hopping, unilaterally, standing, rising from the floor, running, jumping, lifting head, and then going down to those that are more easy to perform, such as getting to a sitting position, rising up from a chair, walking, and just standing in place. And these items are assessed from a score of 0, 1, and 2 on this North Star scale. So with 17 items, 2 points possible, that gives a total score of 34, which usually healthy, typically developing children will obtain a North Star score of 34 by about 4 years of age. So here, this just demonstrates some of these tasks. So this is just the rise from floor task. You can see the classic Gower's maneuver, tripods, gets to a standing position. This young man has difficulty standing from a seated position without the arms, can't really jump, has difficulty hopping unilaterally. Here's the classic Duchenne or myopathic gait, difficulty with stair climbing or stair stepping, stair descending as well. So these are some of the functions that are assessed with the North Star. And what we see is actually some significant heterogeneity of the disease. We've learned about this from natural history studies. You're going to hear more about natural history studies from Dr. Hendrickson later as he shares some of the work we've done over the years at really identifying Duchenne natural history disease progression on a variety of endpoints. But what we see is even though the boys don't typically achieve a normal or a maximum score of 34, there is this so-called honeymoon period of time where they're actually showing some improvement or some maturational progress, at which time a peak level of function occurs, followed by then a decline in function over time. And we can actually take some of these parameters we refer to as time function tests, time to rise from the floor, time to walk 10 meters. We assess these all the time in our clinics, and this actually allows us to predict or prognosticate, years to loss of ambulation or going off the feet. So this baseline level of severity is really quite important. This is a really important slide, and it really lays the foundation for what our treatment expectations are with gene therapy. Here, this could be just as easily a time function test velocity as opposed to a North Star total score. But if you treat patients early in the course of the disease, what you see is relative to a natural history or a placebo, you see this improvement in function, which is really quite noticeable. If you treat them later in the course of the disease, during the decline phase of the disease, what we really hope to see is more stabilization of function. We don't necessarily see improvement of function, but we see stabilization of function versus the predicted disease progression. But what's really quite striking is longer term with gene therapy, we are seeing a really quite impressive stabilization of function over time. So obviously, if you treat a young man earlier, they're going to have a higher peak obtained function followed by long-term stability, as opposed to treating later in the course of the disease, where you might have stabilization, but maybe not the peak, the higher peak obtained function. I think to a patient, this is a win regardless. If you're a patient or a family member, any level of stabilization is a win. And when you look, this is really the challenge of doing these clinical trials, is when you look at 1-year outcomes with Duchenne dystrophy, this is the divergence you could maybe hope to measure, which is maybe perhaps fairly modest in a 1-year period of time. But if you follow these patients longer, you can see that really there's quite a substantial potential divergence from natural history. So the treatment benefit that you actually measure is greater as you follow patients for longer periods of time, out to 2 and 3 years. And I think this is in part to provide some context to the recent NSAA data, which was made public by Sarepta, which we'll comment on in a moment. So Dr. Mendel from Nationwide Children's actually treated the first 4 patients with gene therapy. He's now followed these patients out to 5 years now. And they all actually got pretty significant improvements in their North Star scores over their baseline level of function. But it's really quite striking to me is the level of stability when you follow these patients out. Each one, when you follow them out to like years 3 and 4, they're really quite stable over time, and they're not really entering that decline phase of the disease that we see so commonly with Duchenne patients. And the age of these patients is upwards of approaching 10 years of age by the time they're out to 4 years of follow-up. So certainly well into the age range where you would start to expect to see functional decline in Duchenne patients. There then was a placebo-controlled trial, the study 102, where actually they only stratified or only ensured that the proportions of patients were equal in placebo and treated by just the age. So they stratified based on whether a patient was 4 to 5 or whether the patient was 6 to 7. And what they saw was over the course of a year, they saw this significant bump in function, as we may anticipate with the gene therapy treated patients versus placebo. But in the older patients, the 6 to 7-year-olds, they really couldn't measure the benefit. And what's really quite striking here is if you look at the baseline levels of severity, the patients were really quite balanced with placebo in the 4 to 5-year-old age group. But in the 6 to 7-year-old age group, there was this imbalance. So the placebo patients were a lot better functionally at the outset, at baseline, whereas the gene therapy treated patients had much lower levels of function. The FDA sort of interpreted this as, well, they're not really improving versus placebo. It's not working in 6 to 7-year-olds. And in fact, maybe even the treated patients maybe even do a little worse than placebo. But what really wasn't taken into account was these levels of imbalance. And just to give you some flavor of this, the placebo patients all had time to rise values of 3.6 seconds, whereas the treated patients were above 5 seconds. And so when you look at that in terms of predictors of time to loss of ambulation, the treated patients were actually destined to deteriorate and were destined to get much worse very quickly, whereas the placebo patients were actually destined to be pretty stable over the course of a year. So that was why they were unable to measure a treatment effect in that trial. And I want to just point out, when you get above time to rise values above 5 seconds, that really is a relatively poor prognostic indicator for earlier loss of ambulation, shown there on the right. And then we have been involved in the study of the commercial grade gene therapy product. Any time the FDA is going to approve a gene therapy product, they even did this with SMA, you have to conduct trials of safety and efficacy looking at the actual commercial grade product. And this is indeed what was used in study 103, open label, and then this is the commercial grade product was used in the Embark study as well. So what has been done is actually trying to make use of this open control analyses on the commercial grade treated patients, just really using external control analyses. And this is again where the natural history data that Dr. Henriksen is going to be discussing really comes in. You can't run a placebo-controlled trial for 2 years duration or 3 years duration. It's not ethical to do that. So the only way in which you can actually ascertain treatment benefit that's present 2 years out or 3 years out or 4 years out is by using natural history data or external control analyses. And this has been utilized in this population. We actually used 3 sources on the left: the Synergy Natural History Study, placebo patients from the Lilly tadalafil trial, and also patients from the 4DMD clinical trial from the daily steroid arms. And we took patients that met the same inclusion criteria of those treated with gene therapy and had similar baseline time to rise and North Star values. So this gave us a comparison group of 130 patients over 98% of which were from clinical trials. And here's the data we see. Again, the patients treated with the gene therapy seem to be showing greater improvement on the North Star. And interestingly, as we sort of look at the study 102 data in this context, the 4 and 5-year-olds in their placebo-controlled comparator actually did better than the placebo. This kind of makes sense in terms of our prediction there. But in the 6 to 7-year-olds, the placebo patients actually, indeed, when we compare the placebo patients to the natural history data, they actually did about the same. So the placebo patients were almost right on the money with the external natural history patients, whereas the gene therapy treated patients actually were stable, whereas the predicted comparator population actually were showing decline over time. So this really gives us, some reassurance that it is also, the gene therapy seems to be working in older children, not just 4 to 5-year-olds. Although the FDA, I think, was more comfortable with placebo-controlled data, so they did the initial gene therapy approval to 4 and 5-year-old patients. And then when we follow these patients out longer term, what's really quite striking when you follow the patients that Dr. Mendel has treated for 4 or 5 years is the level of stability from years 2 to 4, whereas the natural history comparators are really declining, and not just declining mildly, but really declining quite substantially. And in fact, when you take each individual patient and actually compare them to their predicted trajectory, this is using some of the prognostic modeling that has been done by the CTAP consortium, each patient does better than their predicted trajectory. So I'd like to just show some videos now. Here's an 8-year-old patient that I followed for a long period of time. Typical Duchenne gait pattern, attempting to run, can't really get both feet off the ground at one time. You can see the tremendous difficulty with endurance, subsequent to running. That individual had a 6-minute walk distance of about 600 meters. And here's one of our gene therapy treated patients. This is really pre-treatment, just prior to receiving their gene therapy. You can see the difficulty that he's having ambulating down the stairs pre-treatment. And here he is actually 6 months post gene therapy, and it's really quite amazing. His stair climbing ability, doesn't really look like a Duchenne patient, and pretty age appropriate in terms of his stair descending ability. And this translates to the real world environment. Here he is climbing up the stairs on the right. And look at his the other child climbing up the stairs doesn't look much different actually. And here he is running down the steps in the playground, and again able to run really quite well. Pretty amazing. And Dad is a pretty tech savvy person, and actually got a drone with a camera and actually videotaped his son running in the park school playground. You can see just this joy of movement in this child who's really able to run quite normally, but with pretty amazing endurance. And here is a newly acquired skill, again with the drone video overhead, riding a bicycle on the right. And here he is 2 years post gene therapy, so demonstrating some durability of effect here. And so on the left here he is rising from the floor. That's 2 years post gene therapy, and here he is hopping unilaterally, which you just don't see Duchenne patients doing it. 8 years of age. After 2 years after a therapy. So this family sent me this video. This is 6 months post gene therapy. He's on the trampoline. Now we don't recommend trampoline activities for our Duchenne patients. We've seen sometimes they get high CK values and rhabdomyolysis, so it's not something we necessarily recommend, but it was impressive nonetheless. And just to demonstrate that, we're not just cherry picking patients here. These are actually 5 patients that I've treated for more than 2 years. This patient on the left is 7 years, 4 months of age, 25 months post gene therapy. 7-year, 11-month-old, 24 months post gene therapy. An 8-year, 6-month-old, 28 months post gene therapy. Here's a 9-year, 6-month-old, 24 months post gene therapy. And here's an early 13-year-old patient who isn't running normally, but is still running nonetheless 2 years after gene therapy treatment. So again, pretty impressive durability of effect that we're seeing in these patients. And the FDA, we actually presented the clinical data. The community was really important participants, and the FDA Advisory Committee recommended for accelerated approval of the gene therapy by a vote of 8-6. And here's Professor Mendel and Dr. Luis Rodino-Claypac, the co-inventors of SRP 9001. Immediately after that decision, you can see just after a lifetime of contributions, it was a pretty emotional moment there for Dr. Mendel. And I just want to provide a little context for the results that were just publicly released by Sarepta. This is all data that's publicly been presented by Sarepta in top-line results on October 30th. The confirmatory trial did not hit the primary endpoint based on the NSAA value, but it's really quite striking is that across really all the time function tests, including time to rise, time to ascend 4 stairs, and time to run 10 meters, we're seeing statistically significant results favoring the treated patients over just a 1-year period of time. And historically, this is really historic also in that the SV95C, which is a stride velocity 95th centile based on a wearable device, is really the first clinical trial ever, a phase 3 trial, to actually use the stride velocity 95th centile as a pre-specified key secondary endpoint, and that actually reached statistical significance. So when you think about those videos that I show, it's patients who are getting up from the floor much easier, going up and down stairs much more easily, or running 10 meters. It's not surprising to think that based on those videos that you might see with a more granular objective measure of time function test a statistically significant treatment effect over a 12-month period of time. The challenge we have with the North Star is really as follows here. And this is data that was presented, that was published by Francesco Montoni from the UK North Star Network. And this really demonstrates the time to rise. These are the latent trajectory classes. So this really shows sort of 4 flavors of Duchenne patients. The most severely affected Duchenne patients in the red, and then other trajectories shown in yellow, blue, and the most mild Duchenne patients shown in the green. And what's really quite striking is that once you get to a 5-second rise time, every single trajectory is in the steep upward trajectory. So when you hit a 5-second threshold, you're in the decline phase of the disease. We've actually used that as a milestone in our Lancet publications with some of our steroid treatment effects. It's really an early indicator of onset of disease deterioration, functional deterioration, or decline. And when you look at sort of the, they're showing improvement over time, and then they flatten, and then they start to increase. Now, Sarepta, they actually set as an inclusion criteria for their clinical trial, you had to have a rise time less than 5 seconds. So they were actually measuring the treatment effect in a patient population that was more mildly affected. None of the red curve patients were in the trial because those patients all they essentially never get below 5 seconds, and so those patients were excluded from the trial. But you can see that, in maybe a short period of time, you might at least have a chance to measure a treatment effect using this time to rise measure. And the decline, the beginning of the decline, if you look at those little dots on the left, the decline occurs prior to age 7 in all groups. It doesn't matter what your gene mutation is. It doesn't matter what your age is. The decline occurs prior to age 7. Now, over on the right is the North Star data from the same natural history study. And what you're seeing there is the red patients, the most severe, they hit a greater than 5 second time to rise time, and then shortly thereafter, they lose the rise from floor ability. So this is the proportion of patients that go to a rise from floor score of 0 on the North Star. But the North Star is a pretty gross measure. It's only a 0, 1, or 2. And something like 86% of the patients in the Sarepta trial, the EMBARK trial, had a North Star score of 1 at baseline. So really, if nobody loses the function over time, here you see the data on the right, you don't lose that ability in natural history data until well after age 8. If nobody loses that ability over the course of the trial, everybody starts as a 1 and they stay as a 1. So you can't really measure a treatment effect, even though your time function tests are showing improvement, or you can actually, see objective evidence earlier in the course of a short 12-month trial. And so I think this, is in part an explanation for the result. When you're looking at really high-functioning kids who are 4 to 7 years of age, the North Star over a short-term clinical trial is a really tough one to hit that endpoint. And again, what was really quite striking from the trial results is that you really, there's something like a 90% odds reduction for the proportion of patients who actually worsen to greater than 5 seconds on their time to rise time. So I think, I'm actually optimistic that I think, hopefully the other companies will be successful. This brings us to some of the other therapies that are recently been approved in the case of vamorolone or Agamree. Actually, this was brought forth by Reveragen and Santhera. Now Catalyst is actually the company bringing this forth to the patient population. This is a key change in the backbone or the chemistry here versus prednisone and deflazacort. And really, I think you get essentially a dissociation of the efficacy factor from the molecule and the side effects. So vamorolone seems to be advantageous in terms of bone density and also height and longitudinal height gain. It was just FDA approved, I believe, on October 26th. And this will be, I think, an option for many of our patients, particularly very young patients and perhaps older patients that really are having difficulty with fractures and so forth. So again, there's we understand the mechanism of these steroids in terms of their effect on the glucocorticoid receptor. The side effects actually come from this glucocorticoid responsive element. But again, this particular molecule, the vamorolone molecule, still seems to have the beneficial effects of steroids without the side effects of bone fragility and reduction in growth. I think weight gain is still, jury's still out. It probably depends on the dose utilized, but so far the data looks promising. And then results from a phase 2b trial really showed a significant improvement from baseline on the North Star, as well as, now these are in steroid-naive patients, so it's a lot easier to measure an improvement in North Star if you're doing it in steroid-naive patients. Now, Javinostat is another medication that we don't know if it's going to be FDA approved. The FDA PDUFA date is in December. They actually ran a phase 3 confirmatory trial, which actually hit on its primary endpoint. This is an HDAC inhibitor, which actually increases translational muscle regeneration factors, increases muscle regeneration, There's pro-inflammatory cytokine releases, reduction in fibrosis. This was the phase 3 trial, which was run on givinostat. These patients were all greater than 6 years of age. They actually, interestingly, performed MRI studies to actually identify sort of a target population. These patients, again, 6 years of age and older, they were all on steroids. They looked at the primary endpoint was the 4-stair climb. They also looked at North Star and some other time function tests as well. And they actually did demonstrate a statistically significant improvement in the 4-stair climb over a period of 18 months in this phase 3 trial. And interestingly, the entire population, even broader than those identified as the on-target population by MRI, also showed statistically significant treatment effects. And here you can see the tendency of most of the endpoints. They hit really statistical significance on the 4-stair climb, the North Star, but others trended in the right direction as well. And I think there's really accumulating benefit to givinosat's benefit to patients. I think the strongest of which perhaps is some of the longer-term follow-up, which shows delayed deterioration by 1.7 to 3.3 years in terms of the natural history compared milestones of disease progression. Now there's next generation exon skipping, such as these are really beyond the current exon skipping drugs. These are new exon skipping medications, which are really focused on targeting muscle to a greater penetration, so perhaps a lower dose, less risk of kidney side effects, and also they're generally showing increased levels of dystrophin production. Sarepta has one called a SRP-5051 for exon 51 skipping. This is a charged peptide conjugated antisense molecule, which drives more of the exon skipping drug into the inside of the muscle membrane. There's also exon skipping therapy, which uses these antigen binding fragments to help the therapy reach the muscle cells. Those right now, Dyne and Pepgen have medications that are targeting exon 51. And then others with also interesting chemistries to drive greater exon skipping and greater dystrophin expression, perhaps less dosing frequency required. One is Entrada, the other is Avidity, and they both have exon 44 skipping medications in the pipeline. This is just an example of that proprietary Fab, which targets the TF receptor on the outside of the muscle membrane to really just increase the muscle specificity and drive more of the medication into the inside. But what you see here is actually some advantages in terms of dystrophin expression in tissues such as the heart and diaphragm. And Dyne has several of these in their pipeline. With that, I'd like to shift briefly to what we're doing for the non-ambulatory patient population. And one of the exciting advantages is that of cell-based therapy, which we're using actually cardiosphere-derived cells, Capricor's CAP-1002 preparation. The performance of upper limb has been used as a primary outcome measure. These cells themselves are manufactured from essentially donated hearts, which were destined to be transplanted, but weren't a perfect match, and for whatever reason were not utilized as a transplant. And so these hearts then are used to essentially grow out their cardiac stem cells, their cardiosphere-derived cells. Interestingly, the cells themselves don't really act by engraftment or by their stemness, but they actually they hone to the pulmonary vasculature where they secrete membrane-laden vesicles called exosomes. And the exosomes have particular cargo, which seems to drive the disease pathogenesis. So again, I think it targets multiple processes with Duchenne. The animal studies show an improvement in fibrosis on both the heart and skeletal muscle. If you actually give the animals just the exosomes themselves, you can actually get the very same results. So you recapitulate the results. So I think this really, these were our results in a Duchenne trial. We published them in the Lancet. This is a phase 2 trial of 20 subjects. This was the target population. They had to have some impairment of their upper limb function. It was really quite encouraging, and we actually saw a statistically significant reduction in deterioration of upper limb function as measured by the performance of upper limb. We also, if you look at the total performance of upper limb score, that also was statistically significant, which incorporates shoulder, elbow, and distal hand function. These were just, you can see, regardless of the performance of upper limb parameter, we saw statistically significant benefits favoring the treated patients. But what was really quite striking is we saw stabilization of left ventricular ejection fraction. So this therapy, even though we infused it IV, actually seemed to stabilize cardiac function as well. And this was our forest plots on the cardiac MRI parameters. We also saw a relative reduction in creatine kinase MB as a total percentage of CK. So again, this is more of a cardiac biomarker for improvement. Just want to spend a moment on what we're now doing is there really have been no trials or therapeutics which have been focusing on Duchenne patients that have lost hand-to-mouth function. You in fact have to have hand-to-mouth function to get into most of your clinical trials. Here's a young man on the left. You can see he's got limited arm function. He would never get into a clinical trial in this day and age. And we've actually fit him with a passive exoskeletal device with motor actuation assist. And you can see the power wheelchair is actually driving the improvement in arm function. There he's able to reach down from his side. So this actually is driven by the power wheelchair battery. Here's an individual feeding themselves. There's actually a dampening feature, so you can actually, if the individual's driving their power wheelchair, they can actually dampen the level of excursion by the exoskeletal device. Runs off the power wheelchair battery. Here he is adjusting his glasses. Here's an individual feeding themselves, actually getting a large cup, up to their mouth. Again, brushing teeth independently, doing scratching nose, scratching the scalp, and then also doing a variety of other tasks. So with that, I will end. I think again exciting developments in Duchenne dystrophy. I'd like to just acknowledge our team at UC Davis, and with that, I will hand the next presentation over to Dr. Henriksen. Thank you.